Arterial blood gases, ABG interpretation. ABG is a blood test that measures oxygen levels PaO2, carbon dioxide levels PaCO2, and pH levels, acidity or alkalinity. ABG is a crucial test that helps doctors diagnose and treat various medical conditions by measuring oxygen, carbon dioxide, and pH levels in the blood. ABG analysis is a crucial diagnostic tool in critical care, anesthesia, and emergency medicine. Provides insights into oxygenation, ventilation, and acid-base balance. ABG analysis is crucial because it checks oxygen levels, checks carbon dioxide levels, and checks acid levels. This helps doctors make informed decisions, diagnose conditions, monitor treatment. ABG analysis helps doctors understand how well a patient is breathing and if their body is working properly. Components of ABG. 1. pH. Measures acidity or alkalinity of blood. Normal, 7.35–7.45. 2. PaCO. Partial pressure of carbon dioxide. Normal, 35 to 45 mmHg. 3. PaO. Partial pressure of oxygen. Normal, 80–100 mm of mercury. 4. HCO. Bicarbonate concentration. Normal, 22 to 26 meqL. 5. Base excess B reflects metabolic component. Normal, -2 to +2 meqL. 6. SAO. Oxygen saturation. Normal, 95–100%. The 6 components of ABG are important because they help doctors. 1. Check if the blood is too acidic or alkaline H. 2. Measure the level of carbon dioxide PaCO. 3. Measure the level of oxygen PaO. 4. Check the level of bicarbonate HCO. 5. Evaluate the body's metabolic balance base excess. 6. Check the percentage of oxygen in the blood SAO. These components work together to give doctors a complete picture of a patient's respiratory and metabolic health, helping them to diagnose conditions, monitor treatment, make informed decisions about patient care. Indications for ABG analysis. Respiratory distress, suspected acid-base disorders, monitoring mechanical ventilation, shock and critical illness, drug overdoses and poisoning cases. ABG analysis is indicated in these situations because it helps 1. Assess breathing problems, respiratory distress. 2. Diagnose acid-base imbalances, suspected acid-base disorders. 3. Monitor ventilator support, mechanical ventilation. 4. Evaluate critical conditions, shock and critical illness. 5. Manage overdoses and poisoning, drug overdoses and poisoning cases. ABG analysis provides crucial information to guide treatment and improve patient outcomes in these life-threatening situations. Steps in ABG interpretation. 1. Assess pH, acidosis versus alkalosis. 2. Evaluate PaCO, respiratory component. 3. Evaluate HCO, metabolic component. 4. Determine compensation, partial versus full compensation. 5. Assess oxygenation status, PaO and SAO. The steps in ABG interpretation are important because they help 1. Check if the blood is acidic or alkaline, pH. 2. Evaluate the respiratory system, PaCO. 3. Evaluate the metabolic system, HCO. 4. Determine if the body is compensating for any imbalances. 5. Check if the patient is getting enough oxygen, PaO and SAO. By following these steps, you can 1. Diagnose acid-base disorders. 2. Identify respiratory and metabolic problems. 3. Determine the severity of the condition. 4. Develop an effective treatment plan. 5. Monitor the patient's response to treatment. This systematic approach helps interpret ABG results accurately and make informed decisions about patient care. Figure 1. Identifying the primary. Let's break down the figure. Acidemia, low pH. High pCO2. Respiratory acidosis, lungs not removing enough CO2. Low HCO3. Metabolic acidosis, kidneys not removing enough acid. Alkalemia, high pH. Low pCO2. Respiratory alkalosis, lungs removing too much CO2. High HCO3. Metabolic alkalosis, kidneys retaining too much bicarbonate. Normal pH. No abnormality. No acid-base disorder. Mixed acid-base disorder. Combination of two or more acid-base disorders. This figure helps you identify the primary process affecting the body's acid-base balance by looking at the pH, pCO2, and HCO3 levels. Sampling sites. Radial artery most commonly used. Brachial artery. Femoral artery. Dorsalis pedis artery. Ulnar artery. Artery must be superficial, easily accessible and compressible with good collaterals. Wrist. The radial artery is the most commonly used sampling site for ABG analysis because it is 1. Superficial, easy to access. 2. Easily accessible, located near the surface of the skin. 3. Compressible, can be compressed to stop bleeding after sampling. 4. Good collaterals, a good backup blood supply at the wrist. This makes the radial artery a safe and convenient site for sampling, reducing the risk of complications. The other options, brachial, femoral, dorsalis pedis, and ulnar arteries, can also be used, but the radial artery is generally the preferred site. The Allen test is a simple medical test that 1. Checks blood flow to the hand. 2. Evaluates the radial and ulnar arteries. 3. Ensures it's safe to draw blood from the radial artery. The test is done by compressing both arteries, releasing one artery, checking hand color, repeating with the other artery. The test helps determine if it's safe to draw blood from the radial artery and avoids potential complications. Arterial pH. Acidosis pH less than 7.35. Metabolic acidosis. Low HCO3 bicarbonate. Respiratory acidosis. High PaCO2 carbon dioxide. Alkalosis pH more than 7.45. Metabolic alkalosis. High HCO3 bicarbonate. Respiratory alkalosis. Low PaCO2 carbon dioxide. In simple terms, if the pH is low, acidic. Check. HCO3 for metabolic acidosis. PaCO2 for respiratory acidosis. If the pH is high, alkaline. Check. HCO3 for metabolic alkalosis. PaCO2 for respiratory alkalosis. Some possible complications associated with taking a sample for ABG analysis. 1. Hemorrhage, hematoma. 2. Distal ischemia. 3. Infection. 4. Numbness. 5. Arterial spasm. These complications can be minimized by using proper technique and sterile equipment, applying pressure to the puncture site after sampling, monitoring the patient for signs of complications, using alternative sampling sites if necessary, providing clear instructions and follow-up care to the patient. It's essential to be aware of these potential complications and take steps to prevent them to ensure a safe and successful ABG analysis. The equipment needed for an ABG arterial blood gas test. 1. Antiseptic solution, to clean and disinfect the skin. 2. Gloves, to prevent infection and ensure a sterile procedure. 3. ABG kit, a specialized kit containing the necessary equipment for test. 4. Preheparinized syringes, syringes with a small amount of heparin to prevent blood clotting, and a 22 to 25 G needle for puncturing the artery. 5. Local anesthetic, to numb the area and reduce pain. 6. Gauze, to apply pressure, stop bleeding after the test. 7. Suture adhesive bandage, to close the puncture site and secure the gauze. 8. Plastic bag with ice, to keep the blood sample cool and preserve it for analysis. These equipment are essential to ensure a safe, sterile, and successful ABG test. Types of acid-base disorders. Primary acid-base disorders are either respiratory or metabolic. 4 potential primary disorders exist, which may be identified by analysis of pH, HC03, and PaCO2. Patients come either with no compensation, partial compensation or full compensation. They may have simple disorders of mixed disorders. These disorders can be uncompensated, no correction of the imbalance. Partially compensated, some correction, but not complete. Fully compensated, complete correction of the imbalance. Additionally, patients can have simple disorders, one primary disorder. Mixed disorders, multiple primary disorders occurring together. Understanding these concepts helps diagnose and treat acid-base disorders effectively. Respiratory acidosis. Causes: COPD, chronic obstructive pulmonary disease. Hypoventilation, breathing too slowly or shallowly. Neuromuscular disorders, e.g. muscular dystrophy, spinal cord injuries. Symptoms: confusion, apnea, shortness of breath, headache. Treatment: improve ventilation, help the patient breathe more effectively. Oxygen therapy, provide extra oxygen. Bronchodilators, medications to open up airways. The goal of treatment is to increase oxygen levels and reduce carbon dioxide levels in the blood, which can help alleviate symptoms and improve the patient's condition. Respiratory alkalosis. Causes: hyperventilation, breathing too quickly or deeply, anxiety, fever, sepsis. Symptoms: 1. Lightheadedness. 2. Tingling. 3. Tetany, muscle cramps or spasms. Treatment: 1. Treat the underlying cause, e.g. address anxiety, fever, or sepsis. 2. Slow breathing, help the patient breathe more slowly and normally. 3. Sedation, if necessary, to calm the patient and reduce hyperventilation. The goal of treatment is to reduce the rate and depth of breathing, which can help normalize the blood's pH level and alleviate symptoms. Metabolic acidosis. Causes: 1. Diabetic ketoacidosis, DKA. 2. Lactic acidosis. 3. Renal failure. 4. Diarrhea. Symptoms: 1. Small breathing, deep, rapid breathing. 2. Confusion. 3. Fatigue. Treatment: 1. Correct the underlying cause, e.g. treat DKA, renal failure, or diarrhea. 2. IV bicarbonate, if necessary, to help neutralize excess acid. The goal of treatment is to address the underlying cause of the acidosis and restore the body's acid-base balance. IV bicarbonate may be used to help correct the pH imbalance, but it's not always necessary. Metabolic alkalosis. Causes: 1. Vomiting. 2. Diuretics, medications that increase urine production. 3. Excessive bicarbonate intake. Symptoms: 1. Weakness. 2. Muscle cramps. 3. Arrhythmias, abnormal heart rhythms. Treatment: 1. Correct volume depletion, replace lost fluids. 2. Potassium replacement, restore normal potassium levels. The goal of treatment is to address the underlying cause of the alkalosis and restore the body's acid-base balance. Correcting volume depletion and replacing potassium can help alleviate symptoms and normalize the body's pH levels. Compensation mechanisms. 1. Lungs. Compensate for metabolic imbalances, fast response, within minutes. 2. Kidneys. Compensate for respiratory imbalances, slow response, within hours or days. There are 2 types of compensation. 1. Full compensation. The pH level returns to normal. 2. Partial compensation. The pH level improves, but is still abnormal. The lungs and kidneys work together to compensate for acid-base imbalances, with the lungs responding quickly to metabolic changes and the kidneys responding slowly to respiratory changes. ABG case scenario. 1. Case 1. Respiratory acidosis. PaCO 55 mm of mercury high indicates respiratory acidosis. pH 7.30 low confirms acidosis. HCO 27 MEQL normal suggests that the kidneys have not yet compensated for the acidosis. Diagnosis: respiratory acidosis, likely due to COPD. 2. Case 2. Metabolic alkalosis. pH 7.50 high indicates alkalosis. HCO 30 MEQL high suggests metabolic alkalosis. PaCO 45 mm of mercury high indicates some respiratory compensation, but not enough to normalize the pH. Diagnosis: metabolic alkalosis, likely due to severe vomiting. 3. Case 3. Metabolic acidosis with respiratory compensation. pH 7.20 low indicates acidosis. HCO 15 MEQL low suggests metabolic acidosis. PaCO 32 mm of mercury low indicates some respiratory compensation, as the lungs are trying to blow off CO to compensate for the metabolic acidosis. Diagnosis: metabolic acidosis, likely due to diabetes, with some respiratory compensation. In each case, the ABG results help diagnose the underlying acid-base disorder and guide treatment. Example 1. J is a 45-years-old female admitted with the severe attack of asthma. She has been experiencing increasing shortness of breath since admission 3 hours ago. Her arterial blood gas result is as follows: pH 7.22, PaC 255, HCO 325. Follow the steps. pH is low, acidosis. PaC O2 is high, in the opposite direction of the pH. HCO3 is normal. Try your hand at it. Here's a clue. Since the pH is acidosis and the PaCO2 is high, in the opposite direction of the pH, it suggests that the acidosis is caused by a respiratory problem. The high PaCO2 indicates that the lungs are not ventilating properly, leading to a buildup of CO2 in the blood. Given that the patient has asthma and is experiencing shortness of breath, it's likely that the respiratory acidosis is related to her asthma attack. What type of acid-base disorder do you think J has? Example 2. 55-years-old admitted male with recurring bowel obstruction has been experiencing intractable vomiting for the last several hours. His ABG is pH 7.5, PaCO2 42, HCO3 33. Try your hand at it. Here's a clue. The patient has been experiencing intractable vomiting, which suggests that he has lost a significant amount of stomach acid HCl. This loss of acid would tend to increase the pH of the blood. Looking at the ABG results. pH is high, 7.5, indicating alkalosis. PaCO2 is slightly elevated, 42, which could be a compensatory response to the alkalosis. HCO3 is elevated, 33, which suggests that the kidneys are retaining more bicarbonate to compensate for the loss of acid. What type of acid-base disorder do you think this patient has? Example 3. Mr. Abg is a dialysis patient who has missed his last 2 appointments at the dialysis center. His ABG results. pH 7.32, PaCO2 32. HC3 18, PaO2 88. What is the primary disorder? Is there compensation? Try your hand at it. Here's a clue. Mr. Abg is a dialysis patient who has missed his last 2 appointments, which suggests that his kidneys are not functioning properly. This can lead to a buildup of waste products, including acids, in the blood. Looking at the ABG results. pH is slightly low, 7.32, indicating acidosis. PaCO2 is low, 32, which is in the same direction as the pH. If it were a respiratory acidosis, PaCO2 would be high, HCO3 is low, 18, which suggests that the kidneys are not able to retain enough bicarbonate to buffer the acid. The low PaCO2 suggests that the lungs are trying to compensate for the metabolic acidosis by blowing off more CO2. What type of acid-base disorder do you think Mr. Abg has? Example 4. Jane Doe is a 45-year-old admitted to the emergency unit with a severe asthma attack. She has been experiencing increasing shortness of breath since admission 3 hours ago. Her ABG result is as follows: pH 7.22, PaCO2 5 mmHg, HCO3 to 25 mmHg. What is the acid-base disorder? Try your hand at it. Here's a clue. Jane Doe is having a severe asthma attack, which suggests that her lungs are not ventilating properly. This can lead to a buildup of CO2 in the blood. Looking at the ABG results. pH is low, 7.22, indicating acidosis. PaCO2 is high, 55 mm of mercury, which is in the opposite direction of the pH. If it were a metabolic acidosis, PaCO2 would be low, HC3 is normal, 25 mm of mercury, which suggests that the kidneys have not yet had time to compensate for the acidosis. The high PaCO2 is a strong indicator of a respiratory problem, and the low pH confirms that it's an acidosis. What type of acid-base disorder do you think Jane Doe has? Example 5. pH 7.38, normal range, 7.35–7.45 PCO2 49 mmHg, normal range, 35–45 mm of mercury. PO2 39 kPa, normal range. Not explicitly stated, but typically around 10 to 13 kPa on room air. HCO3 19 mmol/L, normal range, 22 to 28 mmol/L. Beat base excess -2 mmol/L, normal range, -2 to +2 mmol/L. On these values, we can interpret the acid-base status as follows. The pH is slightly low, but still within the normal range. The PCO2 is elevated, which suggests that the patient may have a respiratory acidosis. The HCO3 is low, which suggests that the patient may have a metabolic acidosis. The B is slightly negative, which confirms the presence of a metabolic acidosis. However, since the pH is still within the normal range, it's possible that the patient has a compensated metabolic acidosis, where the kidneys have increased bicarbonate reabsorption to compensate for the acidosis. But, considering the elevated PCO2, it's more likely that the patient has a mixed disorder, with both respiratory acidosis due to the high PCO2 and metabolic acidosis due to the low HCO3. What do you think? Conclusion. ABG interpretation is vital in diagnosing and managing critical conditions. Systematic approach ensures accurate diagnosis. Always correlate findings with clinical presentation. ABG interpretation is crucial for patient care. A step-by-step approach ensures accurate results. Clinical presentation and ABG results must be considered together. It's not magic understanding ABGs, it just takes a little practice. Thank you. Answers. Example 1 equals respiratory acidosis. Example 2 equals metabolic alkalosis. Example 3 equals metabolic acidosis with respiratory compensation. Example 4 equals respiratory acidosis. Example 5 equals respiratory acidosis with metabolic acidosis. Questions. Hey everyone, I want to hear from you. What questions do you have for me? Comment below and I'll do my best to answer them. #AskMeAnything.